My name is Felix Munger, and I will be one of the two trainers today. This is Zoe Gordon. I'm going to give you a very quick overview of my background. I actually have a background in psychiatric nursing from Switzerland, so I'm not a registered nurse here. But my background is psychiatric nursing, and I've done a lot of work at the Center for Addiction and Mental Health around health equity. I was their diversity consultant for a while, internal consultant. I was a diversity trainer. Then later on, I did some work with the region of Waterloo on evaluating their diversity and inclusion program that they developed locally and so on. And over the last 3 years, I had the pleasure to work with many of the organizations in this room and in the Mississauga Halton LHIN to help each of you, in partnership obviously with the Mississauga Halton LHIN and Summit Housing and Outreach Programs, and many of you helping organizations and the system as a whole to move on the, as Ed would say, the needle on health equity forward.
Thanks, Felix. And I'm Zoe Gordon, and my background is also in addictions and mental health. So I've been in the field for about 14 years, 12 of which was also at CAMH. We have a joke in this LHIN that about one of every two of us somehow was at CAMH at some point in our career, but a proud member of this community, so really happy to be here in the last 2 years managing OneLink, which is our central intake for addictions and mental health for the adult population in Mississauga and Halton. My training and background, I was a recreation therapist back in the day, and then over the last 8 years have been in administrative roles managing the emergency department at CAMH, and I've completed my master's degree in quality improvement and patient safety. And certainly these equity and equality piece, I think for all the data we do in our work, I have to say from just a ground root level, this is the most usable one. So what we've done in really bringing that experience from OneLink today is we've implemented these questions as of July of last year, and we'll bring that into the training as well.
So piece we want to say and make very clear at the very beginning, this training is not our training. We didn't develop this. This training was actually developed based on research by the Mount Sinai Hospital at Toronto Public Health, the Center for Addiction and Mental Health, and St. Michael's Hospital. There was research that was done there, and then the training was funded and developed the Mount Sinai Hospital and the Toronto Central Local Health Integration Network. What you have in front of you, we'll talk about the manual as well. These are documents that are already existing, and this training is being used across at least the Toronto Central LHIN, and I'm assuming it will probably be used more and more across the province as a training on how to ask those 8 questions. So our role here is essentially facilitating this process of making this come alive and making you hopefully be able to walk away at the end to understand what health equity is, and more importantly, how to ask those basic 8 questions. Health inequity, an example. In 2016, just now, Health Quality Ontario actually produced a report where they identified that the poorer you are in Ontario, the more likely you are to have worse health, receive worse health care, and die earlier. Right? This is what poverty does to people. Health is more than the lifestyle choices that people make. So it has to do more with the kinds of environments being different, the social and cultural marginalization, for example, than it does with some of the lifestyle choices that people may make, like smoking and drinking. And we've already told you quite a bit about some of those reasons why this is happening. But why is it important in care? Because in quality care, when it was defined about 10 years ago, redefined, they put equitable in there. So that's where it really comes up as well as part of why it's so important in healthcare. I couldn't help it, but for those of you who were at the symposium in March of 2015, may remember what Kwame Mackenzie said during the symposium that was held locally here. And he said, if you don't count people, they don't count. So if you don't collect socio-demographic data, then you really cannot offer quality care. So this is this link. If a healthcare system wants to provide quality care, then socio-demographic data has to play into this and has to guide the process to become better quality care. So what's the path to health equity look like? So you start over here with socio-demographic data collection. That's the starting point over here. And the interesting thing about this is that it actually has an impact on potentially three levels. So it has an impact at the organizational level, at the client level, and at the systems level, which the MAC kind of made disappear. It's somewhere down here now. But it's about, and I'll talk to this very, very quickly. For most of you, what you're probably quite interested in is what does it do at the client level? And we will have an opportunity to check this out for each of those questions, how they actually impact the way we think about the kind of treatment or the kind of services we provide to a particular client. If we start knowing the socio-demographic information. At the organizational level, we'll also talk a bit about this, but it's about figuring out suddenly that a certain group of clients may be accessing a particular service quite often. So how can an organization shift in terms of addressing that specific group and the need of that specific group?
Yeah, I was just going to jump in. So for us at OneLink, we've been collecting this data since July of 2015. And exactly to that point, what we found in our data to date is 1 out of every 10 individuals who is screened through OneLink would prefer to speak in a language other than English, which represents 17 different languages. So that was my aha moment, where I realized really local data, we really have to back everything up. We can't just be saying, do you need an interpreter? We need to ask people, what language do you prefer, and create a really welcoming culture to say, if you'd like to speak in Urdu, absolutely, we can facilitate this process exactly in Urdu, and then build over time and say, if we have a certain percentage of individuals, not just 1 in 10 representing 17, what are those core languages that our community's asking for? Then we need to change some of our hiring principles and practices and not just have an interpreter, but have, I'll use the example of an Urdu-speaking service coordinator who can really connect not just on language, but on cultural principles as well. That's local data for us. And each and every one of you in the roles in which you have, you get this really rich local data for your organization that you can do something with. I'm also really curious in time is how you can use this data to say, okay, this is who's accessing our services, but measured against who we know who lives in our community, who's not coming to addiction and mental health services, because there is a mismatch. And this mismatch is really frightening. So where do we need to put our focus and really engage different communities that reside within Mississauga and Halton to make sure that we're providing high quality, equitable services?
And that's from the perspective of the organization, but what Zoe said at the very end, you can take at the system level, right? And think about how does for example, a Mississauga Halton LHIN think about that particular issue. Once these data are aggregated up, to create a very, very broad picture of who is locally accessing, what are those socio-demographic variables that we're seeing, and what's the potentially even linked health outcomes and health problems. And then as a system, figuring out ways of how to address this in the long term. Do you want to say something to this?
Yeah, just briefly, this is where we're at. I think we as a LHIN looking to build capacity in that level. So we're not there yet. So we're going to start sort of at grassroots level to build that. I keep saying the robot as we're building it. So this is a bit of where we're moving as a LHIN. That we're able to use the data, the information to really inform how we resource the system ultimately. And we do this through data.
So to bring this back, right, we showed you some health inequities, what can happen. We showed you how, what are the pieces that actually make this happen. Hopefully we're starting to convince you, if you're not yet, that this is good at in fact 3 levels. This is great for the client services that you're providing in your organization to the individual clients. It's great for your organization to start understanding what the kinds of people that are coming to the doors of your services, what they need, and how you can potentially shift the way you do the work in your organization. And then at the LHIN level, it also helps to move this forward. Yes, of course.
Quick example, I was at Toronto Central LHIN Symposium a couple of months ago, maybe a month ago, where I was speaking to a doctor who actually had used in his practice. He actually gives all his patients an iPad where they're able to identify through the socio-demographic data who they are and be able to be. And he shared a story where he actually said that he was able to use the information on income to inform his practice by actually having a better understand how he could prescribe medication for his clients. Knowing that this individual didn't have coverage or insurance. So it's at that client level that you're starting to kind of see some of the good functions and features of using data to inform at that level. So just an interesting story I thought that was my aha moment for me. I said, yes, that makes a lot of sense.
So one of the things that in the community of practice that we're doing through the Mississauga Halton LHIN, where Zoe is very involved in, and Ed as well, one of the things is the reluctance of people to ask the questions. It's a real big issue that a lot of clinical staff or intake staff tend to dislike this idea of having to ask 8 additional questions that can seem quite intrusive. The interesting thing is that what they found by doing this at several hospitals in Toronto, that both patients and clients are willing to share this information. In fact, I think the statistics is that 86% of clients will actually share the information and don't really have a problem with it. That best practice, and we're going to point this out right now, best practice to get the information is data collection at the client intake. So not waiting, do it while the client is in the intake process. And the best predictor of the patient-client engagement is the approach of the data collector.
And we're going to spend a significant amount of time on that part today, because what we've certainly found in the first year, to echo Felix's point, it's not in the client's willingness or unwillingness to answer, it sits with us. We need to really check in with who we are as individuals, what our own core beliefs. All of us are people. We have our own personal life. We also have a professional role to fill. And when it comes to these questions, there can be a disconnect between those. So myself as Zoe might be very uncomfortable with my own beliefs asking one of those questions. But myself as, say, a service coordinator, it is my role to ask those questions and not be biased. I have to check my beliefs aside. So I really want to tackle that today as a group and really make you all comfortable with that and being aware of yourselves. So when you bring back to your teams, that you can really echo that, because I think that's one of the critical training pieces of these 8 questions. And when we certainly work with different teams and practice, a lot of the focus has just been on, well, what if the person says this, or what if the person doesn't want to answer that? And it's all sort of displaced over here. And I think we have to really back it up and say, how am I asking it? And how am I setting it up? So if I'm going to say to Felix, well, the LHIN's making me ask these questions, I got to collect blah, 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 how's he going to react versus, Felix, I'm going to ask you 8 questions, and these help us really understand who you are and how we're going to approach our service delivery. You have the ability to say you'd prefer not to answer to any of them, and I'm just going to go ahead and ask. Very simple, and just go right into them. They're actually written, and when we practice these today, it's like a script. You don't have to go off on a tangent, but when you are going off on a tangent, you need to be self-aware that it's your own level of uncomfortability in asking the questions that you feel you have to over-explain. In fact, if you just read them, and when I listen to our teams every single day, ask them time and time and time again, just like a beautiful written song. They just go through them, and there's no stress or anxiety on their level. It took time, it took practice, but it really comes back to that self-awareness. So we're going to spend more time on that in the latter half today, just to prep you for that.
So, out of the practice and the findings that comes out of the Central Toronto LHIN, those are the main learnings that they've had so far. To be mindful of the barriers around language. One of the pieces that's really important is the piece around discrimination and harassment. And at the community of practice, by the way, if your organization chooses to become part of the focused implementation sites 2.0, the second round, some of the supports that your organization would get is a community of practice that has, I think, been quite helpful for some of you, being able to come together and address some of those things that come up over and over again. But the point here is that discrimination and harassment, so an experience of discrimination and harassment, for example, as a refugee, may make people not want to share certain things based on the notion that they may be afraid that they're not going to get the same kind of service that they could be getting otherwise if they actually answer certain things in a certain way that sounds more preferable, for example. So those are some of the issues that come up. And also, really important, and Zoe did that, right? So she said, all of these questions, you don't have to answer those. It's voluntary. You can just say, I prefer not to answer these.
Why would we ask? So let's look at more broadly. So why would we ask somebody the same set of questions twice? Circumstances change, right? I mean, some of those questions are static, some are dynamic. I mean, were you born in Canada, yes or no? That one's not going to change. That is or it isn't. But your income's going to change. Your sexual orientation may change. Your gender may change. And it's important to understand that that's fluid in somebody's lifespan. So we need to acknowledge that. And where somebody may start their journey at healthcare or service delivery might be very different. So if we take one pod that refers 100 people to pod 2, that pod 2, how does that data change and shape over time, and what do we need to understand, and which parts of our population are potentially falling off by not getting access to services so we can help build up those inequities. I'm going to go back to Ed's point because that one really was a second aha moment for me. We ask so much data of people who come through our doors that I call it cold data. We collect it, right, and it rolls up somewhere. But the person, and we've all been on the receiving end, right, where we get asked questions about our own healthcare. We're not really sure where it goes. When you speak about the approach, how we can use these as teachable moments for health inequities. So if we're using the income one, how that can help shape the conversation at intake around, you know, if I'm prescribing a medication for you, how is this going to impact? And then it can bridge off to say where those supports can be. And when we can use these 8 questions to really form engagement with each individual family member that comes through our doors, then we are as a system tackling those health inequities that have always existed because there's that disconnect between data and service delivery. Sure, so I'll answer that twofold. So just certainly I can only speak to our experiences. About 97% of our service delivery is over the phone in current state. We have yet to have one individual refuse to answer the questions in its entirety. Okay, so that just speaks to that. The engagement over the phone, maybe that it's helpful because there is that disconnect, that is a protective factor. Maybe it isn't, I don't know. I only have that one lens. In terms of the prefer not to answer, there's high variation between the questions. Certainly, we've got to still do a deep dive into each and every question and age brackets, right? So if you look at, and we've talked about this as well, sexual orientation, if you're asking a youth and their parents present, are they going to answer honestly, right? As opposed to, and we don't ever know who's in the room with the person on the other end of the phone, right? Coming back to it, and I don't want to take too much time away from this, but again, looking at our lens as the asker, a lot of the feedback we've had from the training is people are, what about the data integrity? Like, let's look at, were you born in Canada? I don't think the person was telling the truth. Okay, it's not up for us to judge. This is self-reported data, and again, that cadence in which we ask and our own level of comfort, it gives a snapshot of people's self-reported stances around equity and equality. So just to really resonate that piece. I can honestly tell you it takes a minute. It really does. I mean, I've seen lots of tools where there's a promise to the time and the actuality is way over here. This one takes maybe 1.5 minutes.
I want to acknowledge that everyone in this room has skills and expertise and a lot of experiences and training in this. So it won't really come as much of a surprise of the kind of things that make most sense and will get you answers in the way you approach this by, introducing yourself. We do this all the time. In this particular case, explain the purpose of the demographic data collection. And to do this, there's all these resources that I just showed you where you can find them. On the website, you can use the manual, right? And so on the website, you can find brochures for people with speaking different languages and so on. And they suggest that you say, our organization is changing the way we collect information about our clients to help us provide better services, ensure quality programs. It's that simple, right? I mean, who doesn't want that? Who's not willing, to be there? And the key pieces is to say the information is kept confidential. You have the options not to answer, and if you do, that will not affect the treatment that we're providing you with. If you say, I don't want to answer any of those questions, it will take a few minutes. So maybe sometimes it takes a bit longer than the minute or 1.5. And again, that it's completely voluntary. We've talked about it.
We've touched on it, and I think it comes back to your point around the time and the investment in that, and just and think about from what do our clients need to know and what do we need to know, and a lot of it's what we need to know and the time to aggregate the data and analyze it. That doesn't factor into this, just takes a minute to ask. So if we can just start there, we can collect data over time, and when we have the resources, do something with it, but the actual collection is such a minimal amount of time.
They're responding to any client questions, right? Obviously, there's a whole set of questions that clients may be asking. Why are you asking those questions? Why are they going to be useful? What do you need to know them for? And so, like I said, right, there is the glossary, the brochure, there's the website, it's on here. And I explain again what will happen with the data, who is this visible to, and what it will be used to in terms of for researchers, and that it will be grouped with other information, and we'll aggregate it up sometimes and influence, but also at the personal level. So
we plan to share it in time on an electronic board. So we'll continuously show what we've learned and how and what changes we're making as a result of that data to bring it alive. So then each next person that comes in can understand and really make it real as to why we're asking those questions.
Last year, we got to do a bit of research in the Mississauga Halton LHIN, and we asked organizations, healthcare providers in the Mississauga Halton LHIN, what do you actually ask already out of those 8 questions? So we found that what was well established in some form or another amongst the organization was the questions around disability, language, gender, racial, ethnic groups, particularly in the mental health and addiction system, and education. Those were some of the questions that were asked. In need of attention was questions around sexual orientation, income, French services, education. Yes, so in mental health and addictions, that was done a lot, but not generally speaking a lot amongst the health service providers, and if people were born outside of Canada. Those were some of the questions that were not asked. To give you another way of looking at this is what happens. So red is no. Sexual orientation, as you can see, was the question that was the least asked. The second one was income, and then we go to French, education, born outside Canada, and so on, and you find this disability. There's about 90% ask the question around disability. 70% ask language questions. Over 50% ask the questions around gender. Just to give you a sense, so a lot of you are doing a lot of those questions already. Peers, users in care, to provide the appropriate care delivery, right? To acquire informed consent actually is an important one for users in care. I didn't think of that one, right? But if people don't really understand English that well and would prefer to speak a different language, and then you ask them for informed consent for a procedure or something, right? You need to know this. This is an important question. And then, of course, improve access to care for those who do not speak or read English or French. So that just gives you a sense, right? The impact on quality, we know that the use of interpreters and translators has a direct impact on the quality of quality and safety and outcomes for people. So it's a no-brainer, right, in so many ways. Most of you know the healthy immigrant effect. So point here is that people, immigrants come, when they come to Canada, they tend to be more healthy than their Canadian counterparts, but after about 10 years, it actually goes down and goes below that. When we look at the racial and ethnic group, there's so targeted care and supports, so certain illnesses and potentially and so also to think about the populations as well. Use in planning to improve outreach to vulnerable groups who do not seek care at the same level as other groups. So those are the kind of things that help if we move this up, for example, in planning. So the disability questions are about chronic illness, developmental disability, drug and alcohol dependence. All of these are in there, and it's to fulfill organizational responsibilities around providing accommodation. So AODA is an important piece to actually know some of those things for your organization anyway. If
I can just offer quickly to that one of the feedback our team has said constantly is how many people don't check mental illness. And so we've had some really rich discussion on that and the power of self-reporting and that stigma that exists and how we can really take the data of those who are seeking services through us, but don't self-report of having the need, which de facto kind of is why they're presenting in the first place. So it's very interesting.
One of the things that that they're suggesting is that one of the things they found is people don't know what straight means. Right. Or heterosexual. So people don't tend to sometimes not know what that means. And so it's quite, explained that it's the attraction to the opposite sex, right? So then apparently that takes this away. So the second piece that starts happening, and this is probably why those questions aren't really being asked that much, because it's one of those questions that potentially create a discomfort or on both sides, the person who's asking or the person who's responding. So oftentimes, a good amount of times, people will respond, I'm the normal type.
That's so fascinating, because we did not have this discussion when I just touched base with my team briefly yesterday to say I was coming to do this training. I said, is there anything recently that you should update? They said, we're getting a lot of in sexual orientation normal. So it just shows the validity from different perspectives that is just, something to be aware of, that if you hear it, others are hearing the same. And what does that mean?
One of the responses could be, they're all normal. Which one applies to you, right? So if somebody says, I'm the normal one, then to say, they're all normal, so which one applies to you? Did you mean heterosexual? It normalizes everything as an option and kind of pointing out that, don't go that route.
But that, again, keeps coming back to our own level of comfort, right? Because that is the right way. Which of these, they're all normal, right? But we, intuitively, as a person, may have our own beliefs that we have to park in that. So as training this today, I'm going to keep plugging that, because unless we take that piece away, we can potentially do more harm through this experience than do the good in which it's intended.
Income, apparently that is the one question that clients are most uncomfortable responding to. An interesting observation is that women tend to have a higher number of do not know, so actually not knowing what the income is. And the suggestion is ask them to approximate, to give an approximate number of that. And of course, income is, we started with this, right? I showed you the Ontario, the quality report from Ontario on what poverty does to people's health. So you can take this any direction you want to. But the other piece around that one is an important question. Income alone doesn't really tell you that much. It also is very useful to know how many people are being supported by this income, right? So is it, and this is one of the things about how answers are not static. So you could have suddenly supporting your parents, right, as part of your income that you didn't a year ago, or whatever it is, right? Income changes. Somebody could lose their job. Somebody could, suddenly kids are out of the house, and so those are kind of the things that are happening.